Originally formed in 2004 as a local grassroots task force, the New York State Special Education Task Force focuses on improving the educational outcomes of students with disabilities. The task force emphasizes training, issue identification and discussion, and networking. Most importantly, it purposefully promotes participation and collaboration among all stakeholders, including parents, advocates, attorneys, school personnel, service providers, educators, government representatives, and individuals with disabilities. Due to the outstanding success of the model and substantial resource support from Disability Rights New York, the state task force was formally established in 2014. Today, 8 regional affiliate task forces have been established and are built upon a mission to improve the educational access and outcomes for students with disabilities. Through a collaborative, statewide network of stakeholders, the state task force addresses the special education needs of students in New York State. The New York State Special Education Task Force serves 6 core responsibilities. 1, to enhance knowledge and connections to create sustainable collaborations at the local level. 2, to promote a statewide forum for diverse stakeholders to collaborate and promote the improvement in educational outcomes for students with disabilities. 3, to increase awareness of issues and trends in different parts of the state. 4, to increase awareness of proposed and actual changes in law and policy. 5, to increase awareness of and access to resources and advocacy tools. 6, to actively develop regional state task force affiliates in all areas of the state and ensure that each regional affiliate reflects and promotes the collaboration of diverse stakeholders. The state task force would not be possible without the exceptional work of everyone involved. Thank you for your commitment.
And I think that is a good place to stop. And I'm going to share the PowerPoint now. And Sherry, if you want to continue with speaker introductions, that'd be great.
Yes. Thank you very much, Helen, for getting that to play. That's a video that the state task force created, and it's available on the website as well, the state website for the Special Education Task Force. So that's a little bit about what we do and what we focus on. So today, as mentioned, our topic is behavioral health and hard to place students. So those of you that are joining us today, you're going to hear from some very different perspectives from some great people. First, we have Alitza Shaws, who is a licensed clinical social worker, currently employed as a school social worker at Chalmont Central Schools at the middle school. We also have Rose Farah, who is employed as the clinical director at the school at Northeast, the Northeast Parent Child Society, now part of Northern Rivers. And we have Steve Oil, who's employed as a credentialed family peer advocate at Northern Rivers Family of Services. So they'll tell you a little bit more about each of them and what they do when they begin their presentation. So I will mute my mic and turn it over to them.
Alitza, I think you're up, but you're muted. You're still muted.
Okay. I apologize for the inconvenience. So who am I? I am currently employed as a school social worker at the Chalmont Middle School, but I just really wanted to give a snapshot of my past experience, which is clinical counseling and case management, both inpatient and outpatient psychiatric care, private practice, foster care, trauma treatment, administrative supervision, licensure supervision, and most recently working in the field of special education.
Hi, I'm Rose Farah. I am a licensed mental health counselor and currently employed as the clinical director at the school at Northeast. I've been in the field for 22 years. The last 13 of them have been at the school. Started out as a clinical supervisor, then became co-director and now director. A lot of previous experience. You can see it all up there. I won't go through the whole list, but
Good morning. My name is Steve Oil. I have worked in the field of human services since 1987, August of 87. So let's just say that's over 30 years. I've worked in residential care, both as a line worker and as a supervisor. I've worked in a homeless shelter as a care manager and as a maintenance and transportation person. I went back to residential care after being a house husband for my son from ages 4 months to 4 years old. And all the work that I've done, I've been working as a peer advocate, family peer advocate since 2003, I'd say, and been at Northern River since 2007. And of all that work I've done, I am the most passionate and have found my niche in the current work that I'm doing. I loved it all, but this is what I've been best at and what I've enjoyed the most. And I just one reason I wanted to highlight what I've done in the past with the other jobs is because when I was in residential, we used to bring the kids to a private, not-for-profit special school, at St. Catherine Center for Children. And I've done a lot of collaborating from day one, and it's really important. The collaboration is really important, especially with kids with mental health issues that are hard to serve and hard to place. So from there, I just wanted to point that out, and I'm happy to bring my experience to solutions for stuff like this. So I will move on. I think Elisa's next.
I will jump in here quick. We got a note in the chat. If speakers could just be sure to project, that would be helpful. And also if for any attendees who may have trouble hearing, you can try turning up your microphones, and also closed captioning is available. So you can click the 3 dots on the bottom and then you'll be able to see everything that's being said. But now I will pass it off to Elisa.
Okay, well, welcome. We really wanted to kind of keep our eye on what the general goal of the presentation today is. So we wanted to break down what the focal points are so everyone has a clear direction, and that way you can guide your questions at the end. We're going to begin by defining what social emotional health is. We're going to discuss what the factors are that impact social emotional health for children early on, the struggles that are faced by schools in addressing these students, the struggles that are faced by the parents of the students, and also addressing social emotional behavior, both in an in-person and a remote platform. So what is social emotional health? There are lots of different variations in definition, but simply defined, it's the ability to understand and manage one's emotions, reactions, and relationships. A wonderful, succinct description was that our relationships, both in quantity and quality, impact our mental health, our health behavior, meaning our choices of what we're going to do that impact our health, our physical health, and ultimately our risk for mortality. So while there are a number of developmental theories out there, I included Erik Erikson's theory of psychosocial development because I think it's both relevant and accessible for the majority of us out there. His theory focuses on personality development over the lifespan. I included a nice visual graph. Obviously, it starts at infancy. It goes all the way to maturity if you follow it around clockwise. And his belief was really that people went through 8 different developmental stages, and in each stage they encounter a developmental crisis. And the crisis is really when you come into conflict between your individual needs versus the needs of society. by resolving the crisis, his sense was that you develop psychological strength and character traits that help you develop confidence and propel you successfully into adulthood. I included another slide following that breaks down more specifically what happens. So what the psychosocial crisis is at each stage, and then what happens. I'm not going to read them all specifically for you because that would be too redundant, and hopefully you'll have an access to this at a later point. But really the point of including this in here is that it's important to have a framework when we're talking about social and emotional development. All of this is, intrinsically linked. And it's important to kind of have a foundation for what really developmentally we are supposed to be achieving step by step, and how to identify when things go awry or there is a deviation. So if we break down what the factors are that influence social emotional health, it's really important to look at three primary facets, right, which are biological, environmental, and psychological. I gave some examples on this slide. They are not all inclusive by any means, and Rose and Steve will certainly touch on the specifics of this later on in the presentation. But I identified biological as pre-existing conditions or genetic predisposition, which would happen, familial, through in utero. Environmental examples of factors would be poverty, hunger, limited accessibility to resources, poor resource care, parental stress, abuse, and neglect, to name a few. And then finally, but obviously not lastly, psychological, which we could say would include lack of self-esteem, lack of self-concept, poor self-regulation, and or a predisposition to mental health diagnoses, which just means that you are more genetically inclined. And then we get onto the ACEs, which is kind of an all-encompassing concept, which is characterizes the adverse childhood experiences. And I put this on here because this is also very important and relevant when we talk about social emotional health and our youth. Beginning in 1994, the ACEs study, which was a partnership between the CDC and Kaiser Permanente, assessed the relationship between adult health risk behaviors and abuse and household dysfunction. So really, I've already identified the primary facets. So we have biological, environmental, and psychological. So basically what the ACEs did was they rounded up all of the different factors. They included the biological, the psychological, the environmental, and they really captured all of the factors which influence our social emotional health and the potential for deficit moving forward in our life. The next slide will give more specifics. So there are specifics that the ACEs captures on there. Again, I'm not going to read those specifically. You can already see them. But these are specific factors that are going to influence a child's ability for, general well-being and social emotional health. And I included a nice visual here, which really just captures more specifically what the ACEs are, what happens when you are more at risk. I'll just touch on a few of these. People with 6+ ACEs could die 20 years earlier than those who have none, which basically says that all of these factors, they truly do influence what happens to you later on in life. Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. I don't have the date in which he gave that quote, but I would say that that's still pervasive and that's still a relevant statement to this day. At the top, it talks about the predisposition based on ACEs exposure to various medical conditions. And then I think what's most prominent is that 67% of the population have at least one ACE. So I think it's important to reflect on the fact that most people, when they walk into a room, when they walk into a school, we need to kind of keep that in the back of our mind, that they're not walking in with an empty bag, that they certainly have things that they're carrying with them that we cannot see. And that leads us to a very quick video, which I think captures the concept of the ACEs pretty holistically.
And I will play this video.
A backpack filled with notebooks, folders, pencils, markers, all the tools they need to have a successful school day. But as children head out the door, they may also be carrying a backpack you can't see. This invisible backpack is filled with all of the hardships that might keep them from being successful, not only in the classroom, but also in relationships with their family, teachers, and peers. Their invisible backpack may be weighed down with things like anxiety, depression, bullying, family issues like divorce, addiction, abuse, and more. In my early teenage years, my invisible backpack started filling up with lots of heavy things like depression and low self-confidence, low self-esteem. I didn't think I was worth anything, and I didn't have much self-love, and so my invisible backpack got full pretty quickly. You never know what's weighing a young person down. Some students' invisible backpacks may be empty, while others might be overflowing. But with the social and emotional issues children face today, any child's invisible backpack can fill up very quickly. Youth First social workers and programs are
Okay. Back to you, Elitza.
Okay. Okay, so this really brings back what the struggles are that are faced by the schools today. Again, I'm coming from a public school setting, and Rose is going to share on day treatment and day educational programming. But if we look at what the struggles are at the end of the day, what I put in here is that regardless of the origin of the maladaptive behavior and the social emotional symptoms, which we've already really kind of touched on lightly at the beginning of this presentation, the way a child behaves can make them hard to serve, hard to manage, and hard to keep safe in the classroom. So this challenge is not only faced by the teachers and the care professionals, but it's also faced by the parents on a daily basis. And when we speak about what the struggles are that are faced by parents, I'm going to pass it off to Steve.
Thank you, Elitza. I feel like I'm on the news and we're co-anchors when you say that. That was wonderful. Thank you for starting us off. That was really, really good. So I am going to just go through these bullets a little bit. So when a child can't sit still or can't focus or is impulsive, okay, so that's a difficult time for the child. You know, it's easy as the adults to sit back and go, man, oh man, they're very frustrating if they won't even sit at their desk, or they won't sit still, or they won't sit at home. It is frustrating, but we often forget to think about what is the child going through. That's generally not what they want to do. They do want to comply. They do want to be able to do what they're supposed to, pay attention in class and whatnot. And there's a difference between the hyperactive stuff, kind of not being able to sit still. Some kids can sit still fine that have attention deficit, but they can't focus. Their brain does not work well that way. I once heard an adult on a radio show years ago share how, as an adult, when they finally got diagnosed with attention deficit and was tried medication that worked, they shared that, it was like being in a gym, and now I had a coach in like a gym teacher directing my brain about how to process this information. and the person was much more effective, was able to focus, and was much happier as well. So I thought that was a great description. So I wanted to share that. So we see that a lot, the kids and parents and, face. How about outbursts in school for seemingly unknown reasons? So sometimes, even with a biological, um, like Alitza was talking about, even if you're predisposed, sometimes you don't see it early on, or we write it off when kids are little, like they're just little kids. They're just having a little trouble interacting. So maybe it's a little bit later when they're 8, 9, 10, 11, and now they might have some type of mental health undiagnosed diagnosis, and then now they're having emotional outbursts in school. Not necessarily physical, but maybe frustration and anger towards peers or even a teacher. Um, Things that happen that parents get notified about is that child will sometimes on their own volition just go to the school office because they can't function with what's happening. And they don't really have a good skill set. So they decide they're just going to go to the office. And if they're not making trouble or we don't know what to do for them in the school, then they might sit there all day and all we're trying to do is keep them comfortable. And that's not a bad thing for that day, but we have to think about how do we get beyond that. Um, a child leaves a classroom without permission. Again, there's a lot of reasons that might happen. Um, so it might be I can't sit here anymore. It might be because they're getting very upset because they can't function in the classroom. It might be because they're mad at another peer and they can't let go of that and they go looking for them. I mean, there's lots and lots of different reasons. If a child doesn't complete work or turn work in, that's a very common symptom of any kind of attention deficit, where kids actually get homework done, and somewhere between home and school, they don't turn it in. And sometimes it's in the backpack, sometimes it's literally lost. So there's lots of variations in how that happens. But those are kind of common things that parents go through. I think we're ready for the next slide, Helen. Okay, so, yeah, thank you. One of the things Alitza had mentioned on one of her slides that I wanted to point out that, we look at the way children behave, and we look at their behavior and how the ACEs can affect that. Well, I think it's very easy to look at the disruptive behavior and forget about the non-disruptive behavior, but it's still behavior. So in this first bullet, when a child doesn't socialize or is withdrawn, especially if that is not how they have presented up to this point, if they've been kind of an outgoing child for a couple of years and now they're not playing with their peers in elementary school in third grade with lunchtime or whatever. I think believe me, I am not judging anyone at schools. I'm just saying that there's so much that teachers and aides have to do that if a child's not making any trouble, we might miss that behavior. But if a child's not socializing or is withdrawn, that's not behaviorally from like a discipline perspective, that's fine. But for that child, it might be a big red flag. Okay. Kind of moving up that ladder a little bit when a child doesn't play well with others or doesn't socialize appropriately. Again, that might be an onset later in years, middle school, high school. Often it's onset earlier than that. If a child seems fine but is very quiet, that kind of plays off the first bullet a little bit. I want to briefly, before I move on to the fourth bullet, I want to talk about that. So it's easy to see the attention deficit, not focusing stuff. And a lot of professionals learn and can see the not being able to focus even when they're sitting still. So that's good if we identify that. But I think it's very hard for us to understand what clinical depression looks like, for example, and how I think in the vernacular, what we look at is, well, if they just tried harder, if that student just sit and start writing, and then you'll start being able to get work done. But if you've never experienced clinical depression, or if you've never talked with someone or really understand what it entails, it is not just someone that's in a sad mood one day. It is very debilitating. And I think that's something again, withdrawing or just being very quiet in school, there's a big potential that that child might be depressed. And I think we need to be looking at that whenever we can, whether it's family communicating that, those clinical backgrounds, if they have it for the kid, to the school and vice versa. Okay, so child makes threats to other peers. Okay, that's kind of another thing that comes up. Child doesn't follow directions or rules. Okay, thank you. Helen, let's next slide. So some things that happen when some of these, and there's some of you might be out there saying, oh, I can think of another 20 things that happen. I'm sure there are. We're just going to try to stay focused on what we put together for today. But so things that happen for parents is they might receive a call or a text now to come pick up their child because they're having a bad day, or the child's just very upset. They're emotionally not feeling well. Perhaps they've disrupted class with that. I think, let me go to the next bullet. So another thing that might happen, and they might ask a parent to come pick up a child. Parents sometimes get told, hey, they're having a rough day or it's been a rough week. Let's start fresh. It's 11 o'clock in the morning. Come pick them up and we'll start fresh tomorrow. We'll have a new day. And the teachers and the aides and the staff really want the student. They feel bad for the student. They want them to feel better, and they do want them to have a fresh start, and they want them to be happy. Sometimes parents are told that we can't keep your students safe, so you have to come pick them up, or we can't allow certain types of behavior, so you have to come pick them up. In the second bullet, the last quote I have there is that we're sometimes told they have to listen to the adults, looking for compliance. Another thing that parents are asked sometimes if a child's having a hard time is if they're on medication. They might ask, did the student take their meds today? The most obvious example of that is the attention deficit stuff, because when attention deficit medication works, it's usually very obvious that it's working, because the child is able to sit and is able to get work done, as opposed to days where they forget or don't take it, and perhaps they're a lot more hyper, or they're not able to focus. They might sit still, but they're not getting any work done. So what I want to mention here is these are things that parents face, and it's a difficult scenario. Coming from an advocate perspective, I don't want a child to go home just because they're having a bad day at school. I want a student's rights to be protected. If it's a mental health issue and not a behavioral issue, to me, that's kind of a medical thing. So if they're sick, I want that to be addressed. Now, if a kid before COVID, if a kid has a fever, if the parent gets a call to come pick them up because they have a fever, let them have some medication, in a day or two, they can come back, they won't be contagious. That's great. We don't think of it the same way with mental health diagnoses or non-diagnosed mental health behaviors and symptoms. But I think that I work with parents to say that we should work with schools on that. So if a child can't remain in school because they're emotionally dysregulated, their social emotional health is not well, I always encourage parents and schools to we have to address that then. Just sending them home without any treatment is not going to solve whatever the problem was, and unfortunately, there's not always it's usually not a medication thing. So these are kinds of things that come up. I don't know. I just want to ask if Rose or Elitza have anything they want to add or ask me to comment on before we move on. If not, we can just move on to the next thing.
Well, actually, Steve, one of the things that I just really wanted to jump in quickly is, as you're talking about parents getting the call to come pick up their child and things like that, I think that we may, at our program anyway, we may tend to do that a little more frequently. We try not to do it frequently, but a little more frequently early on in a child's placement with us, simply because we're looking for help, we're looking for assistance. The parent really is the person who knows the child better. And so sometimes it does make sense to say, let's start fresh. But in the meantime, let's have a conversation about how we're going to have tomorrow go better, and not make a habit of it, but really looking for for assistance.
I think, I'm glad you brought that up, Rose. I want to just quickly comment on that. That's an excellent point. You know, the best solutions for kids, diagnosed, non-diagnosed, special school, non-public school, that I have found is when there's communication and collaboration
Mhm.
between the family and the school staff. And I think that it, I think that's great. The potential frustration for parents is, especially in a specialized school, if they're getting calls like that, sometimes they're so frustrated just in general before the child started at that school, at your school, that they're like, all right, they're with the experts now. So sometimes when they get that call, they feel like, why are you asking me? But I think couching it the way you just described and saying, look, we have tools, we have things, and we have experience, but we need to know more from you about things that have worked at home, things that haven't worked. So we know number one, not to trigger the child again just by accident.
Right.
Right. So that's a very good point. I'm glad you brought that up.
Right. I mean, and I think the other thing is, I don't believe we ever call a parent with the perspective of blame, or that we're giving up. We do sometimes ask, did they take their medication today? Because, that makes a difference in how we approach the child. If we know a child, when they take their medication, it's very helpful to them, and they forgot today, or so, whatever happened, they didn't take their meds, we know to take a different approach. So that's helpful too. And also knowing if there's something going on at home, we're not trying to be overly invasive or nosy or anything, but again, it can help us. If there's something that's troubling a student, we know, let's be a little more gentle with them. They're going through some stuff. So I think,
Yeah.
I just think, I think you're absolutely right. The collaboration, we absolutely see when we have a strong collaboration with a parent, we see much more success and we see it more quickly.
So the student is better served. And I think, and then we'll move after this, move on to the next slide. But I think to your point about medication, I also was thinking, and even in public school, if there is medication that was forgot, if it's early enough in the day, sometimes they can still get it. Sometimes the
Right.
parent might get it to the school, or maybe you have it at the school or whatever, however that works.
Mhm.
Very good point. Thank you. Okay, this is still me. Aren't you guys tired of me? I'm a little tired of me. Okay, disabilities, conditions a parent navigate. So there are many, many more. I was just trying to point out some that I'm aware of. So again, there's lots of developmental and medical, and here's just a few that parents are navigating. When I say navigate, part of that, I mean, just kind of accepting and dealing with, okay? So Down syndrome and cerebral palsy, autism, and allergies and bee stings and other chronic health conditions that are medical, like asthma and diabetes and whatnot. So there's all of that parents are dealing with. Mental health, I've talked a lot about attention deficit, both the hyperactive and non-hyperactive. The anxiety disorders, so phobias, panic, OCD. I think, again, these are things that, if you think about, I learned this years back, if you think about a duck on a pond that's kind of gliding across the pond, you just see, or any other kind of fowl that swims on the water, they look very peaceful and like they're just chilling out. But if you look under the water, you'll see that they're, what is it, feet, not paws, whatever birds have, whatever ducks have, webbed feet or something. You'll see that they are paddling like crazy to kind of do that movement. And I think it's easy both for parents and for people in schools to look at a kid that's quiet and realize they're doing great. But a lot of times, if they have like a perseverative thought pattern that comes with OCD or with autism, and they get a thought in their head and they can't let go of it, like that's happening a lot of times. And it happened, so that happens a lot. And also mood disorders, again, similar to depression in that it's hard to see unless there's an outburst. But I think about being in a good mood and for no apparent reason, you just switch your mood. All of a sudden you're angry or you're scared or you're sad. Those are very real I probably shouldn't say this, but I'm assuming it seems to be very biological for some people with mood disorders. And if it isn't biological per se, it still happens and it's real in their minds and in their body. They have biological effects for sure in terms of feeling their mood change. Like we can all relate to that if we pay attention to that. So mood disorders, um, they're all very, it's just very tough stuff. So these are things that parents navigate and schools do too. Okay, thank you. You know, I put schizophrenia down there, and I think there's a cutoff age. I'm sure Elitza and Rose would say that you can't diagnose schizophrenia before, I don't know if it's 14 or 16 or maybe 18, but there is schizoaffective, and it's certainly, there are predispositions for that in families. So I still felt it was appropriate to bring it up. Post-traumatic stress disorder, you know, the first two bullets here, that and trauma-informed care, which we'll talk a little more about, you know, really relate to the ACEs study. If you get a chance, you should really, I would encourage all of you that are attending today to, if you don't, or if you aren't aware of the ACEs study, you should read up on that and look at it. There's a lot of information that they collected over years and years to kind of make for the data that we have. And post-traumatic stress disorder, you know, it doesn't, I've learned as a layperson that it doesn't mean if you have a traumatic event that you would get that diagnosis, but it's how you cope with that. And I think one of the things that happens with kids in some households, whether it be in the suburbs, the city, the country, some households, if there might be trauma going on just in the family unit. That's not always the case, but sometimes that's true. So even recurring and repeated trauma can lead to that diagnosis, I believe. So we just have to be open to that notion. It's so easy to look at a kid that is just being oppositional in school or out in the community and saying they're just a troubled kid. They're, you know, they just need to listen to adults. They have to do what we have to say. Yeah, that's like the end of the sentence, but the middle of the sentence is, this is might be the first chance they have any chance that they feel safe expressing their emotions. And maybe they're not able to say, gee, I'm really upset because at home, my parent was doing this or doing that, or I saw my cousin do this. They're not, maybe they can't verbalize it, even as a teenager, because it's such strong emotional and psychiatric stuff. I want to point out that a lot of times in my work with families, even if a kid is not diagnosed till they're middle school or high school with any kind of a disorder or disability, a lot of times parents can look back when we talk about it. You know, there are signs along the way that have happened, sometimes from birth, you know, sometimes from the onset of maybe some outside trauma, or sometimes it just develops and shows, or they only notice it, whatever, 5, 6, 7 years old. So I think when we talk about collaboration, when a parent comes to me, I do a lot of advocacy, but I don't assume every kid that comes to me needs special education. I assume that they need some help. And the first thing we have to do is see if we get a proper diagnosis if they don't have one already. And then from there, see if they need more support in school or not from there. Okay, we're ready, Helen.
I am going to share a nice note that was dropped in the chat that talks about like a student being able to express what they're feeling, and the person gave permission to share this. It says, my daughter's go-to helping adult during her high school years was the school nurse. My daughter has severe chronic mental illness and was having frequent crises events. The nurse was extremely patient and helpful, taking as much time as needed for my daughter throughout the high school years. I established a really good relationship with this nurse and with my daughter's permission. And with some events my daughter came to her for, she called me at work to discuss things. Many times those calls resulted with my daughter being able to calm down enough to be able to go back to classes. This wonderful nurse came to know and start understanding my daughter's needs and personality, and knew when it was I think it's a good idea that your girl be picked up today. This relationship really saved both of us during those years and helped my daughter's anxiety and panic attacks not keep her from developing innate artistic skills and experiences, and to graduate with her classes.
That's an excellent example, and thank you for sharing that. It's really a wonderful story of one person having some understanding and really paying attention to an individual and collaborating with the school and the school collaborating with the parent. I mean, that's what, thank you for sharing that. That's very encouraging and heartwarming, and successful. Yeah. Thank you, Helen. Okay, I think I'm out for the moment. I don't know if that's Elitza or Rose. I think it's
That
Elitza.
is me. I will tap in. So obviously, we've now talked a lot about key factors that influence social emotional health. We've talked about different, predispositions. Steve has really touched on a lot of the struggles faced by parents and really navigating the school system and managing their child with complex needs. But what I think is really important to go back to, and there was a quote on the first slide, I will not make Helen go back. I'm going to read the quote verbatim, which is, the school environment is a key context in which to provide protective factors. Protective factors really being those positive relationships, establishing and maintaining rapport and trust in an effort to counter the effects of the ACEs. So that's the neglect, the abuse, violence, poverty, and hunger. So why that's really important is because, granted, everyone's going to come to the table with different needs and maybe different levels of deficit. But we have a wonderful opportunity in the school setting to really kind of bolster those students and give them an opportunity to be successful. So the services that we do have available at the public level, really, in a more large or macro platform, we provide character education, which is usually provided with the younger age groups at the elementary and early middle school level. Classroom push-in by the social worker or the guidance counselor. Sometimes administrators will go in and play that role as well. We do mental wellness programming projects, different events throughout the school year, and then academic support, right? Because academic support for a child that's already struggling is really paramount, right? We want them to be successful. The other piece is counseling, right? So we provide IEP, meaning the individual educational plan, or a 504 accommodation plan. We provide counseling through those platforms, but we also provide counseling without a formal plan in place. So when a child is in need, we make the necessary adjustments to incorporate them. We have individual counseling, group counseling, and occasionally we provide parent training. Often that occurs more at the elementary level, and you might have a secondary agency that will work in conjunction with the school district to provide parent training, both in person or maybe in the home. We offer a school-wide PBS approach. Some different programs actually have a formalized PBIS approach. In my current setting, we do not, but we do work from the tiered behavioral intervention perspective, and Rose will touch on that further in just a bit. We offer functional behavioral assessments, which is a format for evaluating and assessing different maladaptive, or another way to say is problematic behaviors that surface. As Steve mentioned earlier, and I think goes without saying, sometimes the behavior is less obvious, it's less intrusive to other people in the classroom, but it prevents the student from functioning in the classroom setting. So it's just as relevant and important. And that is followed by a behavioral intervention plan, which would follow the FBA if a child needs a formalized plan in place. We offer shared aids and or one-to-one aid support. And depending upon what public school program you're in, some of them offer different smaller class sizes. So sometimes you have self-contained classrooms. Sometimes you have a co-taught model or a consultant teaching. And you also have instructional accommodations, which I touched on earlier, which is the 504 plans and the IEPs.
Okay, so in a day treatment or day education school setting, the main difference between a public school and a specialized program really is the intensity of the services that are provided. So you're going to see similar services to what Elisa just had up there in a specialized programming. It's just going to be a little bit more intense. Basically, the students that come to a specialized school really don't look that much different than those that are in a public school. So students are placed in an alternative school by their home school district following a meeting of the Committee on Special Education. Basically, the committee, with obviously parent participation, determined that a student's going to be more successful academically if they're placed in a specialized program. And there's two different types. There's typical day treatment program, which is primarily has a mental health focus. They're overseen by OMH. They have psychiatrists, psychologists, and licensed clinicians, and they are the primary mental health provider. And that's the biggest difference between day treatment and day education. Day education students, it's primarily more of a behavioral health focus and is overseen by OCFS. There's no psychiatric staff, and we are not the primary mental health provider, although many and sometimes most of our students have mental health needs and are being seen outside of school for their mental health needs. We do have licensed clinicians, social workers, and that who provide the the counseling, but the counseling is really focused on overcoming the barriers to school success. It's not, the focus is not the mental health needs. Go ahead. So if you look at the different services, Elisa mentioned school-wide PBIS. That is a tiered approach to behavior intervention. We, as the school at Northeast, all of our approaches are based in PBIS, so everything is tier-based. We also have a specialized student support team, and I'll talk more about that a little bit later. So some of the services we do, classroom circles. This is more of a restorative justice or ARC model. ARC is, see if I can remember this, and I'm not. So we're not doing those now, obviously, during remote learning. We can't have class circles in the classrooms. In our program, we also have a sensory room. So kids who have sensory issues can be taken to the sensory room and go through some steps there. Our program does have timeout rooms. A lot of programs have phased them out. We do find them to be very helpful for students. We have therapeutic support specialists. It's 8 staff, and that is their primary focus, is when a child is having real difficulties, the therapeutic support specialists get involved. They also supervise the timeout rooms. So when a child is in timeout, one of the TSS will be kind of talking to them and helping them process what's going on. Every student in the day ed program has a clinician. Every student receives counseling at least one time a week. We also do parent counseling and training. That's usually one time a month. We used to call it family counseling, but it's not truly family counseling, but it really is working with the parents and other family members to help support what we're doing in school, carry that over into home. And how can we as a team help the student be more successful? We also, Elisa mentioned behavior intervention plans. That would be the most extreme form of intervention that we have. Typically, our job at that point is determining, as Steve alluded to, the apparently unknown reasons. we're doing a functional behavioral assessment where a behavioral specialist is going to be observing the student across various environments in the school, and their job is figuring out what is that unapparent reason, because that's the key. That's what we have to be working on to help the child improve. We also do have one-to-one aides for some of our students. All of our staff have training and experience in crisis intervention and problem solving. We basically have all of the interventions, as I said, available at public schools, but more and more intensive. We also have a much higher staff to student ratio. We have 99 staff, and we have anywhere from 115 to 125 students. So that's a really extremely high ratio. Our classrooms are also very small. We have 8 1-1s and 12 1-1s. So that's 8 students, 1 teacher, 1 aide, or 12 students, 1 and 1. But then there's also one-to-one aides in there. So it's not unusual to have 8 students and maybe 4 staff in one room. Okay, the next slide, Helen. So to talk about PBIS a little bit more, the pyramid is how we conceptualize the student body. So if you look at that tier 1, that's usually around 80% of the students. And we take a universal approach with all of them. So basically, this is the way we manage behaviors across the board. Some of the students, their behaviors are a little bit more extreme. So we need to have some more specialized plans for them. We call that the second tier, tier 2. And when a student is referred to tier 2, we all get together, the teacher, the aide, the clinician, parents, and develop a plan. So when this happens, this is what we're going to be doing to help work with that. And hopefully it's when this happens, it's before the behavior actually happens, and how are we going to work with that situation. And then tier 3 is much more formalized. That's when we're getting into an FBA and a BIP, a behavior intervention plan. That's a formalized thing that is part of a student's IEP. It requires periodic reassessing. Every 90 days, we need to look at a BIP and make sure that it's appropriate. So the pyramid can apply to any school anywhere, but typically those students that are in tier 2 and tier 3 at a public school, those are the kids who are coming to our school. So if you think about it from the perspective of that top 20% of students that are creating the problems for themselves and for others in school, those are the ones that come to a specialized program. So every student that walks in the door to us is experiencing some relatively invasive behaviors. So you can go to the next slide, Helen. So what would be seen as tier 2 in public school, that's a tier 1 for us. So that, those children who can't sit still and focus, children who have those outbursts in class, they aren't doing their work or they're not turning it in, they're leaving classroom without permission. While that's really, really disruptive, that's our kids. And we're just more used to dealing with that, I think. Next. So tier 2, again, is that next progression. So any tier 1 behavior may be tier 2, depending on how frequently we see it, how severe it is, how disruptive it is to a learning environment. So a child who leaves the classroom, that's a tier 1 thing. That happens all the time. But if it happens every single day, or it happens every day for one particular classroom or something like that, that's where we're going to sit down and say, okay, what's going on? Why is this happening? Again, that outburst for seemingly unknown reasons, we're going to be looking at that going, you know what? I think every time we move to do math, that seems to be a problem. Let's look at what's going on for math. A child who's making threats, either to peers or to the adults. This is going to be a tier 2 referral, so that we can come up with a plan. We got to have something in place so everybody is safe and feels safe. Go ahead. So tier 3, again, think about that. That's that top, 5%. It's very serious. Children who have moved from threats to actually being physically aggressive or assaultive. Children threatening to bring weapons to school or threaten others in the community. It's not unusual with a child who's at this level to become really angry and to target a particular staff. And they'll say, I know where you live, and they often do. I'm going to come to your house. I'm going to beat up your kid, or I'm going to beat you up, or whatever. We do see that. Or child actually brings a weapon to school. That's the type of behavior that's obviously taken very seriously and is going to get a child up to that tier 3. Probably the type of behavior that would get them withdrawn from public school. Well, they're not going to be withdrawn from our school, but we are going to really be looking at them very, very carefully. So how do we work with this? How are we going to help these kids? So as I mentioned at the bottom, all kids, we have school-wide expectations. PBIS, part of the system is to actually have the expectations posted in every single environment, because what is expected in a classroom is not the same type of behavior that's expected in the gym, or that's expected in the cafeteria, or in the hallways, or the nurse's office. So every single environment within the school has the expectations up there in a visual way, so that they're right there as a visual reminder. Seems a little silly sometimes. You say, well, kids know what they're supposed to do in class, but think about when you're driving down the road, you see a speed limit sign. Well, we all know the speed limit is 55 or 65 on the highway, and yet it's there. It's a visual reminder. So it's really important. We also do regular teaching of those expectations. So the first day back at school, each quarter, we actually sit the kids down and say, okay, let's go over these expectations and just refresh and remind. Actually, the first day of school is a big reminder where we actually move the children through each of the various environments and talk about the expectations in detail there. So I don't want to go through every single bullet. Basically, we're very, very focused on the positive end. One of the things I should have mentioned is those expectations. They don't say, don't do this or don't do the other thing. They say, do this, do this, do this. We try to take a very positive presentation. We also, as a part of that, we reward that positive behavior. So there's an actual token reward system where the child is doing what they're expected, they get points. They carry a point sheet all day. They get points for engaging in those positive behaviors. And at the end of the day, those are tally up and they get banked for them. And they use their in our school, they're called vouchers. And they use those to go to the school store. Our field trips are open to the entire school, not a particular classroom. And the way you get on those is you use your PBIS vouchers. If none of that really speaks to you, you could also just get a gift card, whether it's to a particular store or just a regular Visa gift card. Because particularly with our older kids, our high school kids, getting something at the school store is not a real big motivator, but if they know they can get a GameStop gift card, that's going to encourage them to do better. So when you move up to that second tier, probably the biggest intervention we use at tier 2 is check in, check out. And what that is pairing up a student with a particular staff at school. The story that was mentioned about the school nurse, that would be a typical type of thing. So we would pair a student up with a particular staff. In the morning when they get to school, they check in with that person. They talk about, how did your night go? What's your plan for today? They may be aware there's going to be a test today or whatever. How are you doing? How are you feeling about that? Just checking in with the kid. If there's something going on, that check-in person can talk to the teacher or talk to the clinician and say, hey, so-and-so told me this is what they're feeling today. Maybe we want to take a more gentle approach, or maybe the clinician wants to meet with them outside of their regular scheduled session. And then at the end of the day, the student meets with that person again. And these are only, you're talking like 3 to 5 minutes, but they'll meet with that staff again and talk about how the day go. They'll get, a little token reward, or they'll get, whatever, attaboy kind of thing. What's your plan for getting through the night so that tomorrow can be successful too? That's probably the biggest intervention that we use at Tier 2. This slide says mentoring was not created for our school. We do not have mentoring in our school, although I wish we did. We do small group. That is not just for Tier 2 students. It's throughout the school. Increased parent involvement. It happens in a formal and an informal way. Just by default, a child who's having more difficulties in school, we're going to have more contact with the parent, but we also really want to draw on that parent's expertise to really help us figure out what's the best way to work with that student. And everything is data-based. So we start asking, a teacher may become frustrated with a particular child and say, this is happening every day. And we're like, but you're not logging that. You're not writing that up. We don't have that data to support that. Let's start looking at it. Let's start logging it so that we can see, is it just, it's gotten under your skin and you're really tired of it? Or is it really at the level that you're feeling? So data-based decision-making is a backbone of PBIS. And then, as I said, if we move to Tier 3, we're going to be doing a functional behavioral assessment. We need permission from the parent to do that. So a form will be sent home. It needs to be signed. It needs to be returned before we can start. And then there's going to be formal assessment, formal observation, and collection of data to really help us hone in on what's the precipitating event that's creating this problem. What are we going to do? And the BIP, the behavior intervention plan, is exactly that. You have to identify what is the behavior. What are we going to do when we see it? What do we want to see instead? And what is the incentive that's going to be put in place when we do see that? It's a very, very formalized plan, and something that has to be followed. Again, individual counseling. Well, as I mentioned, all of our kids get individual counseling. There's a lot more parent collaboration when we get to a Tier 3, and there's definitely wraparound where we will be working to develop a really specialized plan for that particular child, which may include all sorts of different things. I can't think of any good examples off the top of my head, but at any rate, the progression is important. So what are the responses? We talked about what are the interventions, and basically when I say intervention, it's like, what are we going to be doing to help prevent the problem from occurring? So then what is the response? So we try to really work with the behaviors within the classroom and really address it without, pulling a whole lot of people involved. So in-class responses, it might be something as simple as proximity. You see the child is getting very fidgety or whatever, and you just kind of position yourself a little closer. Sometimes just knowing that the teacher or the aide is just right there can help a child refocus. Caring gestures, maybe it's just reaching out, put your hand on that child's shoulder because you recognize they're getting frustrated. Hurdle help. Hurdle help is when you see a child's really, really struggling with a particular worksheet or whatever, and say it's math, and you can say, okay, so what's the first step? Or maybe it's, oh, don't forget, carry the one, that sort of little thing. That's hurdle help, just giving a child a little hint, so to speak. And then they go, oh, that's right, I remember, and they can move on. Sometimes it's just a reminder of rules or a reminder of their incentive. It's like, don't forget, if you complete these 3 worksheets, you get to take time on the computer. Just a reminder sort of thing. Sometimes the staff and a student may go for a walk out in the hallway or outside. Kid just needs a break. So what do we want? Instead of having the child continue to get more frustrated, let's just take them out into the hallway, talk it through, have a little break, maybe go outside. We have a really nice garden behind our school. A lot of times you'll see staff sitting out there with a child. It may be moved to a separate location. There's too much going on. There's too much stimulation. The aide, let's go to the library, or let's go to an empty classroom and let's work on it there. Let's just get out of this. I mentioned we have a sensory room, particularly kids who are somewhere on the spectrum, the autism spectrum. They may just take a trip down to the sensory room just because, or children with ADHD as well, just to get some movement in, get some of that energy worked out. That's very helpful. Or they may call the clinician and say, listen, this kid's really struggling. Can you come over and talk with them? Or can you come and can you just kind of give me some ideas? You know, the staff asking the clinician, can you give me some ideas on how to work with that? So that's typical. And that's with basically all of our kids. We're doing that on a daily basis. Tier 2, again, it's all of the above. It's just in more intensive ways. So usually when we're at this point, the tier 1 interventions have already been tried first, unless it's a real severe situation, very acute. At this point, you probably refer the student to the specialized student support team, and an individual plan is developed. But again, that's not a service that's mandated by the IEP. That's just some more intensive wraparound type of stuff. So part of the plan might be, when we see this is happening, the clinician's going to come over to the school and they're going to go take a little, find a little private location and have a little talk. Often the staff, which could be the teacher, could be one of the therapeutic support specialists, it could be the clinician, they may call the parent at that point and strategize. That parent is going to give us some input and some advice on how to deal with it. Sometimes we say, you know what, do you think it would help if you spoke to your child and put the child right on the phone and talk with the parents? We find that to be really, really helpful. It's not unusual for us to put the parent on the phone with the student, and they get it back together and they go on and they have a great day. Again, you might be asked to pick up your student. We really try to avoid that because it tends to be either a reward or an escape, which is also a form of reward. But we might just say, you know what, they're really struggling today. It seems almost cruel to have them continue. If you come and get them, let's have a conversation about how we're going to preset them to come back to school tomorrow and have a better day, rather than have the students struggle through the rest of the day and just really have a real bad time. And as I mentioned, they may be referred to the student support team and develop an actual formal plan. Tier 3, again, excuse me, all of the tier 2 responses probably happened first, if there's time, but some of those tier 3 types of behaviors happen really quickly. A student may get really, really frustrated, particularly with another student, and the threats start happening and all of that. Well, you don't have time to use proximity and caring gestures and all that. You really need to step in. But if we have a behavior intervention plan in place, we're working that. We're going through all of those steps. Sometimes a restraint can happen, but only when absolutely necessary. We absolutely do not restrain kids if we can help it. Restraints are not fun for anyone at all. Sometimes necessary, but not something we look forward to. In a really extreme situation, the clinician is going to sit down and do a formal evaluation. Sometimes we decide that they really should be seen. They're really in a mental health crisis. We need to have them go to the hospital. And if so, the ambulance comes and the parent has to go to the ER and meet the child. And depending on the behavior, police intervention may be necessary, and unfortunately. And whenever we see any tier 3 behavior acted out, a parent will be asked to pick up their student. Because again, tier 3 behaviors, if you recall what those were, those are safety issues. And above and beyond everything, we have to keep everyone safe. I just wanted to mention, you know, the way I have these ordered here, well, it talks about, you know, parent notification. Parents are going to be notified and going to be involved throughout this process. If a child is restrained, we call the parent immediately. Often the child is still in the restraint when we've gotten the child on the phone. If there's been a fight, we are immediately calling the parent and involving them. The parent almost always has been involved as we're leading up to the point where a mental health evaluation is necessary. We really, really rely, I can't stress enough how much we rely on that parent collaboration. Next, so specialized student support team, I mentioned them. The student support team, we have 3 staff. That is their job. It's not something that's like tacked on. It is their job to do the observations, develop the plans, meet with the various teams. When I say team, that is always the clinician, the student, the parent, the teacher, and then any other adjunct staff who may be involved on a regular basis. So, but there are 3 staff who are always involved in every single one of the teams and always involved in all of the planning, because that's their deal. So as I mentioned, tier 2, they develop a plan to specify particular interventions that staff should follow when a particular behavior is exhibited. Good example of this, I mentioned caring gestures. And then that's usually it's just kind of, you know, a pat on the back or a hand on the shoulder or something like that, just to give the kids some reassurance. I have seen on more than one occasion a child who, when they're feeling emotional, they do not want to be touched. So what would become a routine tier 1 intervention of just reaching out? You want to know, don't do that. I've seen kids who have been touched and without, just involuntarily, they just throw up their hand like that. And I've seen staff get punched right in the face. Not an aggression, not something that was intentional, but it has happened. So a tier 2 plan is going to say right at the top, do not touch the child when they're upset. It's a reminder, you know, this is what we do for this child. This is something a little bit outside of what we do for everybody else. And then again, as I mentioned before, tier 3 requires written permission. And that involves then the functional behavioral assessment will be done, and then the behavior intervention plan. When we do this, we have to include the CSE committee because it's going to be included in the IEP. So it's a very, very formalized procedure and a very formalized plan. And I guess that's Elisa.
Thank you. All right, so just before we continue on and kind of wrap it up, I did want to reiterate at the public school level, we have something similar to what Rose just referenced as a support team on the prior slide. We have what is called the RTI, which is the Response to Intervention Committee. And essentially we are a collaborative of AIS, educational support teachers, special ed teachers, gen ed teachers, administrators, social work clinicians, and guidance. And we really follow also the tier 1, tier 2, and tier 3 approaches. And certainly if we get to the point where a child requires the behavior, albeit requires an FBA and or BIP, usually this obviously does go to the Council on Special Education and requires formal permission from parents and other stakeholders. So I just wanted to make sure I referenced that. So kind of taking everything that we've talked about this morning, really wrapping it up in a pretty bow and talking about how we can, I guess, integrate social emotional learning in the classroom. What is social emotional learning? While the majority of our programs, both public and private, don't have formal SEL curriculum, we all do follow a lot of the same model. The curriculum is really intended to address certain target areas, one being social awareness, one being relationship skills, self-awareness, decision-making, and self-management. So that's a lot of what we're trying to do, experientially in the classroom, both in person and remotely. So just to break it down, what is the most important thing? What's been the most salient piece of this presentation is making a connection, right? Without a connection, we don't have anything. You can have a beautiful plan, but the execution will fall short. Assessing basic needs of students. So when we talk about, and we reference back to the ACEs, when we talk about food, clothing, hygiene, really kind of prioritizing, and it really, I'm gonna throw another theory out there, but if you look at Maslow's hierarchy of needs, and when you really break it down, what's going on and what does this child need at the end of the day, what is a priority? Sometimes addressing a behavior is not a priority, right? Making sure that their basic needs are being met is crucial. That's part of social emotional learning. That's part of rapport building. That's part of good practice. Nonverbal communication is huge. I think I read a study a couple of years ago that said that, 55% is based on nonverbal and only, I want to say 5% is word. So basically our nonverbal cues speak volumes. Teaching basic deep breathing exercises. I included some resources at the end for people to access, depending upon our audience, who you are, if you are a parent, if you are a provider. I think it's all still relevant. We did encourage, even in our setting, in our public school setting, we really kind of shared a lot of this material at the start of the school year due to the COVID pandemic, and having students returning to the classroom and also participating remotely. We really encourage the teachers to incorporate these. So practicing group breathing exercises before major events like test presentations. Really validating the student emotions, meeting them where they're at. Again, that goes back to making a connection. I did put on here that mindfulness is critical, helping them stay in the moment. That's incredibly hard to do. That's incredibly hard for a trained professional to do. Everyone in this group. So being mindful of that, we're working with children. They need support, they need practice, they need modeling. And then the last one, you can model how to react to stress, right? So we have a huge responsibility to provide modeling for these students. We need to practice what we preach. Next slide. And then how do we translate this remotely? So this is a huge challenge faced by teachers and care professionals across the board. I think we're still kind of teasing out how to do this and how to do this effectively. Again, we talk about building relationships, that it's going to take a significant amount more time than it would in person. There are a lot of nuances that we experience in face-to-face interactions that you cannot and you will not experience over a computer. And that is nobody's fault. That is the reality of the situation. Spend time acknowledging changes and new routine. What are the pros and cons? So when you're working with a student remotely, I think it's really important to validate where they're at, recognizing what they are resistant to, not coming into the interaction with too much expectation. Structure is certainly important, and it's something that we thrive to provide and reinforce face-to-face. But right now we're trying to make a connection. So the academics, while important, are really secondary, right? Relationship, communication, contact, continuity. These are things that are crucial. And that's what I put at the bottom, right? So adjusting academic expectations of students and expectations of ourselves. I know that a lot of parents are running into this right now. They're feeling like sometimes these teachers aren't quite recognizing, or they do recognize, but they're having a hard time translating that with their expectation, right? So there's still this high expectation of work completion, but we have children that are working, some 100% remote, some hybrid. And some are going in between remote and in person because of exposures. So I think that it's important for the teachers, for the providers, really to take a step back. What do we expect from ourselves? What are we expected to provide here? And how do we best help these kids, right? So while that wasn't, so holistic, that didn't capture all these wonderful strategies that you can apply in the moment, I think it's really important to recognize that we are kind of in uncharted territory. A lot of the activities and strategies that you would use in person, you can certainly creatively use in a remote format, but you need to focus on building that connection. So I have included in the resource page some wonderful activities that you can do. I included stuff for kindergarten through 8th grade, but also working with middle and high schoolers. Again, I think this is relevant and useful for parents and providers and administrators. Certainly we all benefit from an SEL model. And then what was really important, and we touched on a lot, Rose spoke a lot about, was positive behavioral intervention supports. And I think that she shared a lot of information today that may be hard to absorb, but I think it might be helpful to go back, reread the slides, and also check out the PBIS page for more information. I did not include on here, but maybe we can, Helen, after the presentation concludes, something on the ACEs. So providers and parents can go on and really kind of explore what the ACEs is, the history. And some of you may find it useful to actually take the assessment yourself and really look at how you too are influenced by things that happen maybe early on in your development and how that might impact you as a provider and a parent. And to wrap it all up, it's been absolutely wonderful speaking with everyone. This is a very foreign and uncharted way for me as well to present, but I really appreciate you guys being patient with us and sticking around to listen.
Steve, you're muted.
Okay, how about now? Is that better?
Mhm.
I would like to say thanks to Rose and to Elitza. I thought this went very well, all of our planning. I also want to take the opportunity, I like the way you wrapped everything up, Elitza, and I was thinking that I want to give a big shout out to all the teachers and professionals at schools and the parents and guardians and the kids during the pandemic, because I know, it's easy for a parent sometimes to get kind of negative on the system, but I don't prescribe to that. I don't believe in that. It doesn't help, and it's not usually accurate to kind of get stuck there. But one thing I always know is that even if someone's not a good professional in any profession, most of the time the teachers and the professionals there are working very hard, no matter what their effectiveness or what their training or whatever. And I always tell parents that, and I think during the pandemic, it's 100-fold in terms of working hard and trying to figure this out. And there's so many variables about this. So, and the principles I think we talked about today are consistent pre-pandemic and during the pandemic, and they'll be consistent after the pandemic. Hopefully we have more tools when we come out of this for all of us, the kids, the parents, and the teachers. But anyway, I just want to give a shout out to everyone. It's a tough time and everyone's doing the best they can. And I think we're getting through somehow, so.
And I want to give any attendees who called in on the phone, if you have any questions, you can press *6 to unmute yourself. I'll also monitor the chat for another minute or so to see if any questions come. We've got a lot of thank yous coming through the chat. Thank you so much for the information. Presenters did well in presenting and knowledgeable in their areas. Stay safe.
While we're waiting, if I could plug the part 2 of the training which will be on February 9th. I'll be co-presenting with a couple other people, and it's going to be about like, well, how do we sometimes we can't find placements for kids that need even more intense help than we talked about today. It'll be more of a systems kind of discussion as opposed to the details we covered today and what kids need individually and whatnot. It's going to be very good. The two people that are presenting, I'll be helping to present, are very good, and it'll be very interesting. So if you look for that, join our listserv. If you haven't joined the listserv for the task force, Helen can talk about that.
You'll get a link to register for part 2 of this training when you get the evaluation for this training. You'll get an email from me this afternoon. I see someone put in the chat, are we submitting questions now? Yes. You can either put it in the chat, or if you want to ask it, you can unmute yourself and ask it that way. And I will say with questions, this kind of goes for any space like this, keep them general and not like super student specific. It's hard to give advice on giving direct information on what exactly is going to help your student or child.
Plus, we want to respect your privacy since this is recorded. If we were in a big room somewhere, that would be kind of your prerogative. But since it's recorded, we don't want any personal information online.
I have a question. Can you hear me?
Yes.
Great. Thank you so much. My name is Allison. I just wanted to know if you have, I guess, advice or ideas about working with students that are resistant to treatment. So students that are, older, late high school age, and maybe just, sort of flat out kind of, refusing to consider medication, refusing evaluations, just sort of, sort of refusing interventions, and just any advice on navigating when it's actually difficult to even get information on what the student might need. Yeah.
Sorry, I didn't mean to interrupt. I thought you were done. If I could just jump in, I think more than anything, connection, relationship. I think, very often we're eager to be able to make change and be able to start treatment and all of that. And sometimes, and particularly with older kids, that's really difficult. So, I mean, my suggestion, if a clinician were to come to me and say, like, this kid he won't meet with me, or he'll come and he'll sit down, but he won't talk. Really just conversations, just first of all, pointing out to them that they're driving the train. They know it, but letting them know that you know that as well is helpful. But really just trying to get to know them as a person and trying to make that connection, because they've got their shields up. They've probably been hurt by someone they trusted before in some way, or just, when I say hurt, I mean maybe just let down, or they've worked with, we all know the turnover in this field. They've worked with someone, they've gotten comfortable, they've shared with them, and then that person moves on to another job. So I just really think relationship is key. I don't magic.
Yeah, I was thinking the same exact thing, Rose. And I also would like to point out, like, having credibility. So a lot of that comes from listening. And, one story, when I went back to residential after being a house husband, I remember coming into the group home and as the supervisor and getting to know the kids, and I'd say hello the first day. Hi, everybody. I was introduced, and one kid ignored me, and he had, I forget his diagnosis right now, but it was a oh my God, it was like an interpersonal kind of thing. It's going to come to me after the training's over. But anyway, what I did was, the second day I came in, I said hi to everybody except that child. Now, I didn't do it maliciously. I just saw that, like, making a big point out of saying hi to him did not reach him. He was not impressed by that. So I just ignored him. And I didn't say anything bad to him. Now, that's not a standard thing I would say to do, but I guess my point in terms of connection and credibility was I didn't keep on the same path of, gee, I want him to like me or I want him to connect with me, so I'm going to keep trying to talk to him because I'm a talker. That didn't matter to him. And within a week, after ignoring him each time I came in the house, he started coming to me. So I think I pointed out not as a specific strategy, but just as an example of kind of use your gut, your training, your background, know the kid a little bit. One thing I knew for sure was saying hi to him and trying to be nice didn't impress him. It didn't work. So.
Another strategy, if I might, that I have suggested to folks is, I don't know what your role is, Allison, but a clinician says he won't meet with me. So just saying, listen, it's my job. I need to meet with you. So here's what we're going to do. You come, we're going to sit down. You don't have to talk at all. Just sit there. I'm going to do whatever I'm going to do, whether it's, I'm going to type or I'm going to make some notes or whatever, but you're just going to sit there. A lot of kids can't sit there without saying something, or they, some can. But after a while, it becomes, they realize this, you're not going to push them. You're not going to cajole them. You're not going to do anything. And it becomes a safe place. And they just are able to just start talking. Another thing is to just say, okay, let's have a conversation. You pick the topic. You tell me what you want to tell me, or ask me what you want to ask me, and sometimes sharing with them, obviously with boundaries, but sharing with them something about yourself can be helpful. I also had some people who have been successful saying, we're not going to do a session. We're just going to eat lunch. Get our lunch. Let's go to my office. We're just going to sit there and eat lunch together. Not a session. All of a sudden the kid starts talking and it's really a session and they didn't even realize it. So, I think the worst thing to do is to continue to push and push, and that's just going to drive them further away.
So I just wanted to kind of second what was already said. And again, you haven't clarified your role, and I think it's actually irrelevant in the conversation, but it sounds like, the hardest thing to do is to see the writing on the wall for these kids, and to feel like you have absolutely no control. And you don't. You can't control what they choose to do. You can control the opportunities you provide with them, or provide them with, and you can provide them the space, like Rose said. So really just trying to meet them where they're at, not trying to drive any type of motivation when you meet or when you talk. And also sometimes the clinician is not really the one who cracks the ice. And I know that's really frustrating, and I can be honest and say I've been in that position, and it's very frustrating for me as a clinician sometimes when I feel like I can't, I'm hitting a wall and I'm unable to make that connection. And sometimes it's a different person, a different role entirely, and they kind of serve as an intermediary, and they're able to make that connection, right? Because at the end of the day, these kids, they're resilient. And I like to say that they can sniff out BS. And so if you're trying to arbitrarily make a connection because you have a motivation to get information, or you have a responsibility to get, provide a service or get something done, they sniff you out right away, and they clam up, and that's it. So I'd say just, push forward, try not to have too much expectation on yourself about what the end point will look like, and just hope to make a connection, make a positive connection for that teenager, and hopefully that will be enough to facilitate, kind of like a cognitive shift that they want to do something to improve their life.
Thank you. I can just have, that's helpful. If I can just have one additional question. And to clarify, I represent parents in dealing with their educational services for for their children. So for parents who, just a question on any resources you may be able to share for parent, like support groups for parents who are just, at their wit's end with, even if the student is, at a placement and, sort of getting by, who are just really having a hard time with the student at home and just not able, again, like an older student, not able to control their behavior and, dealing maybe even with safety issues, unsafe behavior. I've referred parents to Understood, but just wanted to know if there's other resources that you might recommend for parents.
One thing, it's a little bit broader than that, and you might be aware of this, but if it's students that have mental illness or mental health issues, you could use NAMI, the National Alliance for Mentally Ill. They have local chapters, and I don't know if it's by county or by city, but if you Google NAMI, NAMI, or National Alliance Mentally Ill, you could find support groups. And I say it's broader because I do know, like, you have parents of kids, of people that are adults now, so they might be out of the school system. But if it's a mental health thing, that's a start, and you might be able to make connections through them. You could, I'll try to think of some other things. There are probably other support groups by agency, but off the top of my head, that's the only thing I'm thinking of right now. And if I could just backtrack, I thought of that diagnosis. For the other thing, story I was telling, it was reactive attachment disorder. So it's an attachment thing. And I knew that going in, which is kind of why I thought of that as well. Anyway, I just wanted to share that.
Thank you.
Looks like Dawn, did you raise your hand?
We've got, sorry, not to jump in, we do have a question in the chat. Before I get to that question, I'll add, someone responded to the last question that Parent to Parent of New York State just launched a parent support group for parents navigating the special education field. So that's another resource. The question in the chat was, a concern is terminology used by the state for IEP classifying children as emotionally disturbed. The term can be upsetting for parents when first presented and outdated and offensive, maybe even politically incorrect. Has this concern been presented to the task force and ever addressed as a concern or need for change?
I don't recall that the task force has done anything specific to petition the state or to address that. I believe in the past, we may have done part of a training or a whole training on classifications, but I don't know for sure off the top of my head. One thing I will say, yeah, I agree with you about that's the last one of 13 classifications. I know some school psychologists in Schenectady County will change the terminology and call emotional disability, which is very family friendly and comparatively to emotional disturbance. What I also think, regardless of the title or of the term between that, I mean, the other one that is typically used is other health impaired for kids that have mental illness or mental health issues. One thing that helps, I think, too, is to kind of look at the definitions of the classifications. If anybody wants any info on that, maybe you can put your comment. I don't know, Helen, is my email out there? Or I don't know if we didn't put it on the slides, but people can reach out to me. I can help direct them. If they reach out to you through this venue and you want to forward information to me, I can send people that or a link to find that. But the classifications and the definitions I find are very, like the definition of emotional disability or disturbance. I find it helpful if I need to use it to help get a kid classified. It says basically if it can't be explained by these other things, and there's like 4 bullets in there. So while it is offensive in the terminology, I think it can be helpful when it fits a student, and it doesn't fit all students by any means. But I think the other catch-all would be to use other health impaired and at least bring, and I see a lot of districts using other health impaired for kids that have mental health issues for the reasons I think, they don't explain it, but I think for the reasons you asked about, like that it's much less offensive or, yeah.
If I can just really quickly, you want to be careful with OHI. There are services that a student will not be eligible for after age of 18 if they are just OHI classified. So for instance, going into college, they may not be able to have as many supports if they have an OHI classification as if they have that dreaded ED classification. So just something to keep in mind. Sometimes it might be the better course of action to just kind of, take that offensive title because your child will be better served.
We have some helpful information in the chat. It came from Kristen, who is the co-chair of the task force. She said that there have been general discussions about the classification and that she or the task force will pass the concern and the topic to the statewide task force leaders. And then I think the last question to round it out could come from Dawn. I see that your hand is raised, so if you want to unmute yourself, you can do that.
Hi, thank you so much for the training today. My name is Dawn Euster. I also work at Advocates for Children of New York. And from our experience, we have seen that there are just so few programs and placements that are appropriate for students with emotional mental health challenges throughout the city, the state, and the ones that, even are claiming to be able to support students with significant challenges, whether more externalizing or internalizing. We find that many of them struggle, frankly, to do that with a lot of our students. I think this may have actually even been raised earlier, and I apologize. I've been sort of in and out of the webinar. I've wanted to be a part of the whole thing, but I've been putting out fires in our office this morning. So my apologies. But what I'm wondering is, and ones that we really thought were good, I mean, they've been calling the police on our clients, and frankly, for things that are just, they should be able to manage as so-called, the ones especially that call themselves therapeutic placements. And so what I would love to know is, are there, and I haven't looked at this as something I would need to do, are there standards? Are there state standards? Are there guidelines or recommendations for, there must be, you can't just call yourself therapeutic. And then beyond that is, what is the state or the state task force, if anyone knows, doing to actually check the quality I know that there's the whole quality assurance part of the New York State Education Department and with special education, but it doesn't seem that, I don't know what they're doing. What are they doing to monitor the quality? What are they doing to hear from families about issues and that their children, some of their children are essentially being told that they're not appropriate after they're told that they are appropriate? Knowing the child's behaviors. And I literally was on a call with, I'm not going to call him out, but with the head of a school who literally said to me on the phone of a school that is therapeutic on paper, and it is written as a therapeutic approved school, is that we are a school first. He kept saying, we are a school first and therapeutic second. And some of you may know who I'm talking about. And I'm really struggling with the fact that there just doesn't seem to be quality control. And then when schools are struggling, we need them to be effective. We want them to be effective. And so, what, if anything, is the state then doing and to support and train the schools to help them get the proper certifications and but also really make sure that their staff know how to not just de-escalate kids, but do it in a trauma-informed way. Right? And do those kinds of things. So I know this is a really long question. I don't expect you to have all the answers, but I just really thought this is something important to say, at least ask. And if anyone has any insight, I'd love to hear it.
My very first thought is don't assume that anybody else knows what you know. So when you ask, well, what does the state do to regulate? the presumption, I think, is no news is good news. And I don't know what the mechanisms are for the state to be watching what's happening. So as Rose referenced earlier, like, in my experience, when students have success is when there's real collaboration. So even if you're interacting with people that you feel are not doing what they're supposed to, or maybe you not just feel that, but you know that, don't assume that the state knows or whatever. Also, you have to look at who, to kind of get those standards, who oversees that school. So there's, Rose mentioned in her presentation, the school that she works at is overseen by the Office of Children and Family Services and state ed. Whereas another school in our agency is overseen by the Office of Mental Health and state ed. And while they're similar, there's definitely differences in terms of their regulations. And I have found in my experience over 30 plus years in the language that is used as well in the different departments. So I think you want to find out who they answer to, and then maybe you could find some regulations from there. And then, you know, I know sometimes we don't want to go up the ladder and go over people's heads, but, you know, don't assume that other people know is what I would say. You want to share that, or have the parents share that information with the proper people.
Right. I mean, and if I can jump in, although it seems offensive for anyone to say we are a school first, that really is what it is. I mean, when we say OCFS and state ed, it's really state ed and OCFS. Our students are all held to the same standards as all students in the state. So it's our job to educate them. And it's obviously much more difficult to educate students in that environment. So although maybe the way it was presented, that message, that really is the truth. We really, and we have to educate all of the students. So it is difficult. As far as who's watching, we are audited periodically by state ed. They come in, they pull random charts. They look at everything in great detail. They interview staff, they interview students, they interview parents. It's, you know, there's a lot there. And if you feel that there's something that's not being done correctly, there's always the Justice Center. And I can tell you the Justice Center interviews things in great depth, really intensively. So there's a lot of oversight out there. Not going to say things don't go wrong, things do go wrong, but people do care and people are looking at it and people do take that seriously. So
I just want to clarify one thing. Of course, a school is a school first. I mean, that's very clear. The point in this particular case, and I wasn't going to go on and on about it, was that the school, when we were asking the school, what is the therapeutic part of it, they could not answer at all. And so that was a huge problem. And we were on the phone for about 90 minutes. So there wasn't one example, and there were lots, and I was barely doing any of the talking. It was people who know the child also outside of the school. So I just want to clarify that. And yes, of course, I know that there's general oversight. My point is just that it's not working. It's not working for a lot of our students. And we work with lots of students year after year after year. And I'm not just talking about myself. We work with lots of other lawyers. There's only so many lawyers in New York City doing this work. And we are in task forces and groups with them, and they have very similar experiences. So yes, and of course we could file individual complaints, but that poses some challenges for lots of different reasons, obviously. And then yes, we as lawyers could be like filing complaints on all the schools. It's also a challenging issue for us because we do want our clients to go there. Right? It's not like there's nowhere else for them to go. So it's not just, okay, you know, individuals can file complaints. I think that what I'm suggesting is that there needs to be a better job of those who are, you know, investigating and yes, of course, and where those of us and you who are part of statewide task forces, you know, are, you know, you can also use that, I think, pedestal to share that there really should be a review of these therapeutic schools. I mean, I think, I don't know, the schools can also, of course, they're gonna sell their schools in a good way. They sold, you know, the clients, right? We know that on paper, a lot of them or certain ones have PBIS, and they'll say they do restorative practices. They'll say they do TCIS, but yeah, that you just have to look under the hood. So anyway, thank you for, again, the presentation and answering my question.
I would also say advocate with your state legislature. We need more funding. The funding that's available for ongoing training of staff, the funding that's available for salaries is really, really poor, needs to be increased. Without being able to increase those budgets, it's very, very difficult to keep pace with what's happening in our environment. I will say, I mean, I've been at the school for 13 years, and in that 13 years, the severity of the behaviors that we are seeing has increased dramatically, and it has far outpaced any training that's available for staff. So it's really difficult. We're really struggling on an ongoing basis just to try to keep up with what are better approaches and how do we interact and all of that. So, you know, contact your legislature and get us more funding.